Assalamu alaikum and welcome you to all. Today's session is endocrine. We have one recall session, okay, that I have to complete, okay. So I will take a extra class for this GIT recall, okay, inshallah. As a new member joined, so I decided to take a new topics so that, and the exam is also knocking at the door, okay. So welcome our new member, Dr. Halim Michael. Thank you for joining to us. Okay. So let us start. Just I check that everyone is joined or not. Okay. So, so our topics is endocrine, and these are the resources from where I made the lectures, and the important topics is mentioned here. Okay. So first of all, I have to say that endocrine is very important, and among endocrine, most important things is diabetes mellitus. Actually, the syllabus in the RCPCH side is written like endocrinology and diabetes mellitus. If I said that last year, the total questions from the endocrine was like from the Fop, total questions was from endocrine was 8, and among them 5 was from the diabetes mellitus. So I think you can understand how important is diabetes mellitus. Okay, let us start. There are some endocrine gland in our body, and diabetes mellitus is actually the disease of the pancreas. So pancreas, from pancreatic cell, alpha cell is secreted glucagon, beta cell insulin, delta cell somatostatin, which is actually came in the several time came in the TAS exam. Okay, that you have to memorize very well, from where this hormone release of the from the pancreatic cell. Okay, now insulin hormone is very important. It has several role. It has some effect on the glucose, that it causes uptake of glucose. Okay, and also it helps to protein synthesis, and also it promotes fat synthesis. Okay, so if there is any situation where there is no insulin, then what will happen? There will be no uptake of glucose. Okay, so what will happen? The glucose amount of glucose will be excessive in our body. Okay, as there is no uptake of glucose, so there will be high glucose, that is called hyperglycemic condition, and for this hyperglycemic condition there would be osmotic diuresis, and which can cause dehydration. Okay, and another thing is, as we said, that it helps to protein synthesis. So if there is no insulin, what will happen? It causes breakdown of our protein, so there would be muscle wasting. And if it doesn't synthesis protein, there will be breakdown of fat. Okay, so there would be high like fatty acid products, which lead to ketogenesis. Okay, so what is if there is ketogenesis, then there would be like beta hydroxybutyrate. These types of fatty acid will be high. Okay, so we will discuss this diabetic ketoacidosis, ketogenesis topics later on. So we comes to know the function of insulin, and without insulin, what will happen? Okay, this is very important topics which came several time in the exams. Okay, as we already know that actually some questions repeatedly come in the exams. If we take proper preparation for this, then it will be easy for us to pass the exams. Okay, and now, what is the anti-insulin hormone? So what is the insulin function? Anti-insulin is opposite to these functions. Okay, so there would be like glucagon, adrenaline, cortisol, and growth hormone. These are the anti-insulin hormone. Please remember one thing, what I marked red, it came in the exam several times. Okay, so you have to remember this very well. So we comes to know some basic things now. What is diabetes mellitus? Actually, it is a metabolic condition which leads to hyperglycemia, and basic problem is insulin. Okay, so basic problem is insulin secretion, insulin function, insulin action. So whatever, if there is problem in the insulin, then leads to diabetes mellitus. And there is clear-cut difference between the adult diabetes mellitus than the pediatric age group. I will discuss it. Like for diabetes diagnosis, what just we have to take some random blood sugar. Okay, it's not necessary that we have to take the fasting blood sugar. If just RBS is more than 11 or more than 11, then it would be enough for diabetes mellitus. Okay, and if there is symptoms and fasting blood sugar, okay, 7 or more than 7, it would be also there. Okay, and these things are taken, these diagnostic parameters are taken from the pediatric guidelines. So we have to, for exam purpose, have to follow the pediatric guideline. Okay, so RBS is enough for diagnosis in case of pediatric diabetes mellitus, and it is written that do not arrange a fasting blood glucose or glucose tolerance test for diagnosis. Okay. Now, how can we differentiate these types of, how can we differentiate like different type of diabetes? There are different type, among them type 1 and type 2. As we know that type 1 diabetes is more common in the pediatric age group, and here is pancreatic beta cell is distracted by an autoimmune process. But in type 2 diabetes mellitus is insulin resistance diabetes, where there is like insulin is there, but insulin cannot act on. Okay, so for type 1 diabetes there is no insulin, but type 2 diabetes there is insulin, but they do not appropriately work on. Okay, there can be obesity, there can be positive family history, and the type 2 diabetes having less ketoacidosis. Okay, they usually do not present as a ketoacidosis. The type 1 diabetes is a frequently manifested to us as a diabetic ketoacidosis. Okay. Now, type 1 and type 2 diabetes mellitus is a very well-known thing. There is another diabetes mellitus, that is maturity onset diabetes mellitus, which is also very important, which we will learn. Okay, remember some HLA antigen is associated. We discussed in the celiac disease and different type of disease. You have to remember this. Okay, like DR3 DR4 is related with the diabetes mellitus, and it is there was some questions related with unstable diabetes. What is unstable diabetes? When a person's blood sugar is changing very frequently, like there is a severe hypoglycemia, and then there would be very low sugar, okay, hypoglycemic condition. These types of diabetes is called brittle diabetes or labile diabetes. There is a honeymoon phase. So what is the honeymoon phase? Usually it is occurred for the type 1 diabetes, and where after diagnosis you will find that sugar becomes normal. Okay, you just diagnosis the diabetes mellitus, but after then for some periods there will be sugar become normal. Okay, but it is not like patient is become well. Okay, it's not a disease that you will be okay with with some drugs. It's not like that. It's a lifelong disease, and it is like when you give your advice to the patients, you have to say this is a lifelong disease, and you have to take usually the type 1 diabetes is in the pediatric age group, and you have to say that you have to take insulin for lifelong. But for this honeymoon period, you will find that insulin becomes there is sugar becomes normal, but it is actually for some periods of time that times the pancreas secrete more insulin that maintains sugar for some periods. After then, patient becomes like hyperglycemic again. Okay, so it is honeymoon phase. Okay, so we comes to know that what is diabetes mellitus and for which reason diabetes mellitus is occurred, and what types are there. Okay, and we have to know that how to differentiate between some forms of diabetes. So among type 1, type 2 diabetes mellitus, we have to remember that family history, obesity, these are more in favor of type 2 diabetes mellitus, and type 1 diabetes is more related with some autoimmune disease. Okay, and there is some HLA association like HRT3 and D4. Another thing is autoantibodies, where you find the autoantibodies where autoimmune disease are related, so type 1 diabetes mellitus. But if we count the C peptide, then actually C peptide is high for type 2 diabetes mellitus. Actually, what is C peptide? When there is insulin is produced, then there is C peptide also produced as a byproduct. So if there is no insulin, so where the C peptide, where we find it? Okay, so in type 2 diabetes mellitus, there is high insulin can be high, but insulin cannot act on. So in that cases, you will find that yes, C peptide is there. Okay. Now, for the pediatric age group, already we discussed it, where diabetic ketoacidosis is associated mainly for the type 1 diabetes mellitus. Okay. And another thing is acanthosis nigricans, which is usually associated with type 2 diabetes mellitus, where patient having family history, where there is insulin resistance. Okay, it is a dark velvety color in the neck or armpit. Okay, sometimes they give these things. So you will find how the diabetes present. So if you consider that, yes, the clinical features will be polyuria, polydipsia, weight loss, can be diuresis, can be sometimes their presentation is like diabetic ketoacidosis, okay, like acid on breath, vomiting, dehydration, abdominal pain, hyperventilation. Okay, we will discuss diabetic ketoacidosis later on. So science of pediatrics books related, something we have to read, just use listen to me. Okay, 14 years old girl who was diagnosed with type 1 diabetes, aged 8 years, admitted with episodes of ketoacidosis. Following rehydration and stabilization with intravenous insulin, she was found to have lost 8 kg since her previous clinic visit 6 months earlier. Okay, so patients having diabetes mellitus for the long period of time, okay, since 8 years, now 14 years. Okay, and there is weight loss also. I don't know why interrupting. From my side, there is network is okay. So do you hear my voice? Is it okay? If it is not, then I have to change my network. Is it okay? Please let me know. Do you hear me properly?
Yes, yes.
Okay. Okay, so if it is interrupting, please check your side network, or if everyone feels problem with me, just let me know. I will change my network. Okay. Okay, so now what I said, that patients having recurrent diabetic ketoacidosis features, and also having reports problem recurrent hypoglycemia. Sorry, patient having recurrent hypoglycemic features, patient having diabetes mellitus for long period of time, having had to reduce her daily dose of insulin. So for hypoglycemia, they reduce to less than 0.5 unit per kg per day. Okay, she does not report any other symptoms of ill health. Inspection of her blood glucose diary shows largely normal blood glucose values, but repeated measurements of her hemoglobin A1C shows values more than 104. So it is normally, if it is less than 6.4 percentage or 64 millimole per liter, then it is okay, but here it's quite high. So you see, they do not give you very clear-cut history. Here they give you this history like diabetes mellitus is there, but recurrent hypoglycemia also, that the needed for insulin becomes very low. But you see HbA1c is high. So for why it is? And there is weight loss also. If there is weight loss, that times we have to think something abnormal here, okay? Because hyperglycemic condition can lead to weight loss, but it is not the hypoglycemia which can lead to your weight loss, okay? So what could be? Is it Addison's? Is it celiac? Is it eating disorder? It is hyperthyroidism or inadequate insulin therapy? What could be? This is very common things that came in the exams, very common things differently. Okay, when we discuss the recall, then you will understand. So here the problem is the eating disorder can be associated and inadequate insulin therapy, okay? Because actually that diabetes mellitus is a long time disease, okay? So it can lead to sometimes some psychological disorder also. At like adolescence age, the pediatric age group people, sometimes they do not want to take the insulin, okay? So that times they give the chart that the sugar is below the average, below normal, and the complaints of that frequently they have hypoglycemic condition, but actually it is not that types, okay? So it reveals that there is some eating disorder. When the patient having anorexia nervosa, that times it is a one type of eating disorder. That times the patient complain for it, okay? Because if they take the insulin, then their weight increase, okay? If they omit insulin, then their weight lose, okay? So it is good for them, they think it. As we know that anorexia nervosa is a psychological disorder, okay? So eating disorder can be associated, and also inadequate insulin therapy, as the HbA1c is very high, that indicates hyperglycemia for the past 3 months. It is not that sugar is below normal, okay? HbA1c do not indicate this. Here they do not give you any features on investigation for Addison's, celiac, or hyperthyroidism. So for this condition, which you can advise, you have to recommend it increased insulin dose, although the patient complains of hypoglycemia, but you have to recommend increased insulin dose. And for eating disorder, you have to refer to the psychologist. These two things you have to do. Okay. So these are the conditions which can happen to the pediatric age group people's diabetes mellitus. Now the maturity onset diabetes of the young. Okay, so this is one type of diabetes which is practically you do not find these types of people very commonly, but you have to know it very well, okay, for the exam purpose. So it is like, it's a autosomal dominant gene is there which disrupt the insulin production, okay? It is called monogenic diabetes. Like type 2 diabetes is polygenic diabetes. In the GIT chapters, we discuss some polygenic condition like pyloric stenosis. Have some genetic influence also. There is some environmental insulin, and type 2 diabetes mellitus also having some environmental insulin. So they are polygenic, but MODY, maturity onset diabetes, is purely monogenic diabetes. Okay. So these types of patient, when the maturity onset diabetes of the young, in that cases, you will find there multiple genes are involved. There are different types. Okay, so how can you understand that this is MODY? By like it will diagnosed incidentally. Okay, sometimes patient comes to us with like gastroenteritis, and that times you do the sugar and accidentally you find that it's hyperglycemia. Why? Then your diagnosis will be ultimately lead to maturity onset diabetes mellitus. Sometimes you will find that patient is diagnosed as insulin type 1 diabetes, but you find that insulin requirement is very low. Okay, after the honeymoon period is over, that times also insulin requirement is very low. It is mostly goes in favor of your like maturity onset diabetes mellitus. Okay, and sometimes like you diagnose a type 2 diabetes mellitus, but here you do not find any obesity. Okay, that times you have to search out for MODY. Okay, and I doesn't mean that if there is if there is no obesity, then it could not be type 2 diabetes mellitus. I doesn't mean it, but I mean it that you have to find out. Okay, that is there MODY can be or not. Okay, so gene testing is the confirmatory test for the maturity of the diabetes mellitus. You have to know this chart. MODY, there are several forms. There are some questions from here. Okay, like if I say that which is most common is MODY 3. Okay, which is hepatocyte nuclear factor 1 alpha. Okay, if there is a hepatocyte nuclear factor 1 alpha gene mutation, you will find, and they are responsiveness mostly to the sulfonylurea. Okay, oral hypoglycemic. So for it is an oral drug. Okay, to reduce the hyperglycemic condition. Which is called anti-diabetic drug. Okay, so and they are different from like MODY 1, which is also response to the sulfonylurea. MODY 2 is a glucokinase gene mutation is there, and patient is mostly asymptomatic and low risk of complication. They do not require any types of treatment. Okay, so these are the things which I mentioned. Please try to remember. Now, urine C-peptide creatinine ratio for screening can be a form by which we can by which we can differentiate between the this diabetes mellitus different from. Okay, so we comes to know about MODY and how can we differentiate. Already I say that how can we differentiate from, if I differentiate it from type 1 diabetes mellitus, then it is usually early age of their presentation type 1 diabetes, but MODY is adolescence age group, and strong family history is related with the MODY more. They are autosomal dominant, they are monogenic genes, and they have like moderate elevation of plasma glucose, where type 1 diabetes you will find severe elevation. Okay, and MODY is usually require sulfonylurea, but type 1 diabetes mellitus you have to give insulin. Okay, so I think MODY little bit different. Otherwise, it's not very difficult. You have to go through it. That maturity onset diabetes mellitus is different. It has some genes. It is autosomal dominant inheritance. Sugar, blood sugar is not so much high. Insulin is not required here, and it is usually incidentally diagnosed. Okay. Now, if you diagnose it, baby of child like diabetes mellitus, how you proceed? Like this patient can be diagnosed by the GP, or you can diagnose as in your A department, that accident and emergency department. This is called emergency department. Okay, so in that cases you have to refer the patient to the diabetes team. There is a diabetic team where there is pediatrician, endocrinologist, there is the nutritionist. Okay, and diabetic team consists of it is written here. Also social worker is there. Okay, patient support group is there. Diabetes team is very important for the UK. why I say it, that there is some recall questions related with these things. Okay, that diabetics team and diabetic, they frequently arrange some some program, okay, which is very helpful for the patient. Okay, now every patient after diagnosis, they are given some chart that they have to maintain. Okay, and when they comes to follow up, they will take it. Okay, like these types of chart is given. Okay, like sometimes the patient become hypo, or sometimes it is normal. Okay, so sometimes ketosis is there. Everything is written here. So how you will manage a patient with diabetes mellitus? You will manage a patient with some insulin. Okay, it can be rapid acting insulin. It can be like rapid acting insulin is mainly short acting insulin. Okay, there are sometimes long acting insulin is there. So there are some questions that what is the following, which are like short acting insulin, which are long acting insulin. So we have to some common names. Okay, insulin Lispro, insulin Aspart, like Humalog, Epitra, Novorapid. These are the short acting insulin. Their duration of action is short and faster onset of action. Okay, some long acting insulin like Glargine and Detimid. These are the long acting insulin. And how you manage, you have to refer the patient to the diabetics team. They will advise, but you have some conception that we give the insulin usually for when there is no complication by subcutaneous insulin, and total daily dose is 0.5 to 0.75 unit per kg. This is the total dose. Okay, and in the Fop case book, we just, for the exam purpose, we just always will follow the guideline, and also we can take reference from the Fop case, task case, or sub books. Okay, but new updated guideline, BSPDA guideline, we can follow it. Okay, which is mainly used in the UK. So if it is written in the books that we can give the insulin different way. Okay, like a pre-mixed insulin, both short and long acting insulin as a 2 divided dose, or sometimes 3 divided dose. But best one is to give short acting insulin with each and every meal, and long acting insulin 2 divided dose. Okay, morning and night. Okay, basal bolus regimen, long acting insulin in the morning, night, with short acting insulin in the meals. It is the best way, I think. Another thing is insulin pump therapy. Nowadays, insulin pump therapy is used. For which patient insulin pump therapy is used? If they have like labile diabetes mellitus, okay, frequently hyperglycemia, or frequently there is hypoglycemia, or patient age is less than 2 years. That times they it is very difficult to maintain their feedings and to maintain their insulin level. That times we can use the insulin pump therapy. Okay, where they are there is a pump given, and where rapid acting insulin are used, and pump always delivers the amount of insulin every few minutes. Okay, every few minutes, and long acting insulin are not necessary that times. Okay, so it was also a questions that what type of insulin is used, insulin pump. Okay, so after then there is no questions actually. How you please give the patient's age is such and such, please give the patient insulin, or please write a prescription. It is never came in the exams. Actually, it is not like solely on the doctor's role. It has some role on the like nutritionist, and it depends on several factors, patient's meal, preference of meal. As in the pediatric age group, we do not want to restrict their foods very tightly, as it can lead to their like protein breakdown. So actually it's teamwork, and there are several types of like calculator is already available, which is used. Okay, and every time carbohydrate counting is done, then short time insulin is given. Okay, short acting insulin is given with the meal time. Okay, so there is a it is not came in the exams to calculate and give the insulin. Okay, so you have to know the basic mechanism. You have to know how to manage. Okay, how to refer, when to refer. These types of questions frequently come. Okay, so when you give the patient, one thing is every meal you have to count the carbohydrate, what amount of carbohydrate they will give, and they will give the, and you will give the short acting insulin, and also the total requirement of insulin, that is 0.5 to 0.75 milligram per kg per day. And after calculating it, you have to divide, like 40% you will give long acting insulin at night. Okay, and 20% insulin you will give with each of the 3 meal. Okay, and another 40% at morning. Okay, so by this way you give the total insulin by calculation. It is the way, but again I have said that it is not very necessary to know that all the calculation. Okay, for nice to read, okay? You can just read, nothing very important for the exam. Okay, now how you monitor the patients, that is it okay, what insulin you given, is it working appropriately. That times you can check by the HbA1c, which is less than 48. Okay, okay, it is less than 48 millimole per mole is normal, or 6.5%. Okay, you have to know it. So there we comes to know what is the diabetes mellitus, type 1, type 2, maturity onset diabetes mellitus, how can we differentiate it, and also how can we manage with the insulin. Okay, now there are important things, that is dawn phenomena and Somoy effect. Okay, these two things are very important, and you have to know that what is the difference between this dawn and Somoy. So among them, both having in the morning hyperglycemia. You see, both having at the morning you will find hyperglycemia, whereas Somoy having late night, that is 3 a.m. So it is midnight, the patient having hypoglycemia, whereas for the dawn phenomena, there is still hyperglycemic condition. Okay, so you see that dawn having always hyperglycemic condition, no hypoglycemia, but Somoy having hypoglycemia followed by hyperglycemia. Do you understand it? Please let me know. It is Somoy having hypoglycemia followed by hyperglycemia at the morning, but dawn phenomena. Yes, Dr. Taskin, thank you. And but dawn phenomena having no hypoglycemia condition. Actually, dawn phenomena is where when the patient comes to the adolescence age group, then there would be high growth hormone, surge of growth hormone. They have so growth hormone, as there is a surge of growth hormone. So you give the insulin, but it causes inhibition, as we know that growth hormone is anti-insulin. Okay, anti-insulin hormone. So if you give the insulin, then still patient having hyperglycemic condition. It commonly occurs in the adolescence age group peoples. Okay, but here the Somoy effect is different, that here the patient comes to the hypoglycemic condition at the midnight. Why? Because of adrenergic outpouring occurred that time, due to adrenergic effect. Okay, after then when the effect gone at the morning, you again see the hyperglycemic condition. So for these types, what you will give as the patient is for the Somoy having hypoglycemic condition, so you have to decrease the nighttime basal insulin, that is long acting insulin. The insulin you give for night times, it will maintain your sugar for the whole night. Okay, so if you read about the patient's hypoglycemia at midnight, you have to decrease the nighttime insulin, basal insulin, okay? And for the dawn phenomena, what happened? There insulin, there is inhibition of insulin, okay? So there is persistent hyperglycemic condition. So you have to increase the nighttime basal insulin, okay? Morning time is okay there. So you have to, sorry, morning, not morning time, all the day is maintaining, but at midnight to breakfast, there is hyperglycemic condition. So that times you have to increase the nighttime long-acting insulin, okay? So this is the main difference. Frequently these questions came, okay? If you do not understand, you can ask me in the group anytime. So, okay, again, you have to read and you have to think, then you can understand this. I gave all the things required here, okay? Now, very important things is diabetic ketoacidosis. Actually, in the UK, the rate of pediatric diabetes is highest in the European region. Okay, it is the highest, the incidence is very high, okay, pediatric diabetes. So that you have to know the diabetes very, very well, okay? Because you are preparing for UK, UK social, UK regional disease, okay? So you have to read the diabetes very well. Now the diabetic ketoacidosis is mainly BSPD guideline. Okay, they follow the BSPD guideline. This is the British Society of Pediatric Endocrinology and Diabetes Mellitus. Okay, these are the now the new pediatric guideline, that is 2021. Okay, red color. Sorry, not red color, that is green color. When we gave the exams or read that times, it was red color. So always we talked like a red book, but now it is become green book, okay? So in that, they change many things for the diabetic ketoacidosis. So my lectures is on the new guideline, okay? So you can go through the pediatric guideline as well for this diabetic ketoacidosis. So diabetic ketoacidosis, which is diabetic ketoacidosis, it is having high blood sugar. It have to be acidosis condition, and there would be ketonemia. Okay, these three things you have to remember. There is hyperglycemic condition which lead to fatty acid. Actually, there is no insulin, which lead to fatty acid breakdown. There is more ketone, which can lead to ketonemia, and this condition lead to ultimately acidosis. Okay, and this is diabetic ketoacidosis. Usually the diabetic ketoacidosis is mainly present as a gastroenteritis, like severe abdominal pain. Although patient having severe abdominal pain and patient having diarrhea sometimes, but patient is dehydrated. Okay, patient is very dehydrated. So we initially think of that patient